So thank you for the opportunity to present. Thank you again for the CRAFT COVID Committee for this award. I am new to this group. I don't think I've met hardly anyone on this call, but as way of introduction, I work for UCI Health. I'm a chief of geriatric medicine and the director of a senior health center, and we focus on the care of older adults. So our project is Healing at Home. As you mentioned, it's a geriatric ED feasibility study to reduce hospital admissions during the pandemic. And as noted, you know, we are going through a surge, and actually our ID experts anticipate, you know, a magnitudes of orders of increase in the fall. So we feel like this is a very timely period to conduct a feasibility study. So our response to the COVID challenge is to find alternative ways to care for subacute patients, freeing up the hospital resources for that time when the hospital needs those to really focus on the COVID care. So the purpose of this will be to establish a framework for a hospital at home program. The feasibility study will establish the foundation for this, including the specific protocols, resources, challenges, personnel, etc., and should eventually lead to an intervention study. And again, this is a stepped up effort to keep those subacute patients at home to free up the hospital beds. And the target population is a very key component because these are the folks that are most affected or at least suffer the most complications. They're over 65. They often have chronic illness such as diabetes, hypertension, heart failure, infections. These are the folks that need to be sheltering at home. And so we want to reduce their exposure, especially when they're sick with a comorbid illness. I won't go through this in detail given the time, but I have cited some references here for your review if you'd like to see them later. But there is actually a very robust growing evidence for hospital home models across the country, and geriatric programs across the country are investing in this at a rapid rate. We have seen meta-analysis showing reduction in mortality, readmission rates, cost, etc., as well as patient and caregiver satisfaction. So in general, I just want to go through the process. Initially, our first month will be a month of preparation and foundation for establishing the workflows, processes, etc. And this includes training for the emergency department personnel in regards to what is possible at home. So we have access to preferred home health agencies across Orange County through our patient care. And they are capable of many, many interventions, including IV fluids, IV antibiotics, complicated wound care, you know, extensive monitoring, etc. And some of this information and their capabilities isn't really acknowledged yet by providers, either in ambulatory care or the emergency department. So in essence, when a patient presents, and we will work with the ED closely to understand which type of patient can be cared for safely at home rather than coming into the hospital. They will be triaged to the subacute hospital diversion program, and our program coordinator will work with an emergency room coordinator to set up the transition to home, meaning we'll set up the home health care, and then we'll set up the geriatric follow-up via our new telehealth initiatives. So once the patient is safely at home, then the home health nurses, the home health, and our project RN will work closely along with our geriatric physicians to establish the intervention and follow through the treatment plan. We do have 2 geriatricians who will be the backbone of this program and will be available 24/7 support day and night for the home health agencies, as well as the emergency department. And then team 3 includes an extended resource, including our ACO team. I'm also the medical director for our ACO for UCI Health. So we have a very robust team of health coaches, pharmacists, social workers, and NP. And they're very expert at attending to all of the needs all of the gaps in care that can therefore keep people at home instead of in the ED or in the hospital. Okay. So in terms of the overall outcomes, our primary outcome will be a reduction in hospital utilization, including further ED visits and inpatient hospital admissions. We will measure these outcomes against a comparative cohort with ED patients admitted with similar baseline metrics and diagnoses. Our secondary outcomes will be to understand the patient and family experience and satisfaction, as well as the providers throughout the continuum, meaning the emergency department personnel, as well as the geriatricians and the external home health providers. And our third outcome will be a cost analysis, including the hospital home cost of care. We will compare that to the potential inpatient care setting as if hospital home were not an option. We will be establishing, as I said, the protocols and foundations in August. We'll be running the 2-month intervention in September, October, followed by a 1-month observation. And as I said, as this surge continues throughout the fall and the winter, then we anticipate to be ready to help with the surge ongoing throughout that period of time. And I just want to acknowledge the team. We have geriatricians. This is a collaboration with the School of Nursing. So we have our nursing and evaluator colleagues, we have colleagues from the emergency room, as well as evaluators, the ED coordinator, and case management, external home health agencies, and our ACO team. So it's really pulling together a number of resources to establish a foundational program, which we think will be extremely helpful and critical during COVID, but probably even ongoing. And so I'm open for questions. Thank you.
Okay, thank you very much. We're running a little short on time, but we have time for at least one question. Well, I do have a question. So
yes.
This has heard a couple of times about using artificial intelligence algorithms to triage patients coming into the ED. So the question is, are you working with that team, and do you have special adaptations of that algorithm for your risk group in particular?
That's a wonderful idea. We do not, although I think as we continue and seek further funding, I think that would be a very valuable component. At this point, we are relying on clinical expertise from the ED as well as the geriatricians. But I think that would be a fantastic component to add to the intervention study which will follow.
It might be interesting to confer with them now and see if they've done any separate profiling of the older population, actually.
Okay, great. Thank you. I'll take that back to our group.
Yeah, we can put you in touch with them.
That would be wonderful. Thank you.
Sure.